This meeting is being recorded.
Good afternoon and welcome to today's webinar titled API Orchestration and FHIR Workflows. My name is Jeanette Wider and I'm Managing Editor of Healthcare Innovation. Today's program is sponsored by Infor. Thank you to our sponsor and to our audience for giving us your time and attention today. Before we get started, we have a few housekeeping details. To submit a question, please use the Q&A box to the left of your video window at any time. You do not have to wait until the end of the program. For technical issues, please press F5 to refresh, and if that doesn't work, you can submit a question with your issue through the Q&A panel. Finally, join our webinar conversation on Twitter. You can tweet using the hashtag #HILiveWebinar. At this time, I'd like to introduce Jörg Schwarz, Senior Industry and Solutions Strategy Director at Infor. So it's nice to see you today. I would like to begin by talking about, you were recently at some of our summits talking about API and FHIR workflows, right?
Yeah, absolutely. Nice to see you again, Janet. Yeah, we were at the Seattle and the Los Angeles summit. Great summits, by the way.
Oh, good. We always like to hear that. So I was thinking we could start the conversation by you giving some examples of these API and FHIR workflows.
Yeah, absolutely. Would love to do that. So we see that the interest in FHIR is picking up. Obviously, FHIR is not a new standard. It's been around for 10 years. But if you can go to the next slide, I talked at the summits about a couple of use cases. One of them being IoT devices and remote monitoring. IoT devices generate a massive amount of data, and you need to capture that data. You need to separate signal from noise and then stage the data before you push the data that is really useful into the EMR so the doctors can look at it and can bill for it. There's also another set of use cases, the social determinants of health, where you want to connect with APIs for non-traditional healthcare services, for example, transportation or social services or food delivery. So there's a lot of innovative things that you can do by orchestrating these type of workflows. And then we've seen during the pandemic a big uptick in hospital at home with remote monitoring of data. A lot of these workflows you can support through application programming interfaces, which is a more modern style than a traditional HL7 v2. And then I also talked about the interactive payer integration, which is something that the Cures Act will mandate. And a lot of customers are asking us what that really means, and they are looking at this as a way to really get into FHIR and connect FHIR with the traditional architectures.
Okay, so why is there so much interest right now surrounding this?
I think it's because of the payer integration and the burden reduction workflow that now our customers, the providers, are paying attention to this, and obviously also at a bigger scale, the whole transition towards value-based care, where payers want more data for their value-based care purposes. So there's really a need to get high quality data, and HL7 FHIR data is much better suited for all kinds of analytical purposes and also value-based care purposes than the traditional HL7 v2 data.
Okay, and I know you talked about the Cures Act, but how does this relate, if you can elaborate on that for us a little bit today?
Yeah, the Cures Act gave us a couple of new options. It started with ADT notifications for primary care physicians, which is very useful in the context of value-based care. The Cures Act also mandated info blocking rules, which means that providers and payers have to exchange data. It initially didn't say how, but now we're getting more and more specification in how the data needs to be exchanged. Recently, we saw a specification. Originally, it was only specified that what has to be exchanged is US CDI, the US core data set. This has now been expanded into all healthcare information that is made to make that is collected and stored to make clinical decisions. So that just happened last month, this expansion. And then the next thing is going to be the workflows that we're talking in detail about later today, the burden reduction workflows which require a data exchange between providers and payers.
Okay, and I have one last question for you today. So at our summits, your message to the audience really said that this can be accomplished on top of existing infrastructure without really the need to rip and replace. So how exactly can that be accomplished?
Yeah, absolutely. If you can go to the next slide, that's the exact slide that I showed at the summit. And what I was explaining is, if you look at the left side of the slide, you see the existing legacy infrastructure. This is the HL7 infrastructure that we've been building for the last 2 decades, with HL7 V2 used to exchange data between the lab system and the EMR and the PACS systems for medical imaging. Cloverleaf is the #1 interface engine in the world to do these type of exchanges. What we have built is infrastructure that allows us to connect this legacy infrastructure that transacts millions of HL7 V2 transactions every day to the modern world of APIs and FHIR. Key here is our product called Cloverleaf FHIR Bridge, which can sit on top of any HL7 V2 infrastructure. It automatically translates the data from HL7 V2 into FHIR and from FHIR into HL7 V2. And that allows you, in combination, for example, with our API gateway and the Cloverleaf FHIR server, to orchestrate modern API workflows and to also orchestrate this payer data exchange that we will talk about in more detail in the next segment. And for that, thank you so much for your questions, Jeanette. I want to hand it over to Rob Brule. He's our Senior Product Management Director for our FHIR products, and Viken Ohanessian, who is one of our solution consultants. They will talk in detail about these workflows and actually show how this works in detail. So, Rob, over to you.
All right, thank you so much, Jorg. And so we'll start off with this slide in particular, because Jorg mentioned several workflows, and we're going to talk about payer-to-payer data exchange, clinical data exchange, and exchange of data for prior authorization. But I wanted to mention first where those workflows come from. And so in the FHIR-based world, there's a thing called implementation guides, which define how data is exchanged between systems. And it kind of lays out the rules for that particular workflow, what data explicitly will be exchanged, what the handshakes are, and what the sequence of events are. In order to create those implementation guides, members of the HL7 community get together and publish these type of guides. And there's groups within the HL7 organization that are critical to publishing these guides for specific use cases. One of those groups is the Vinci group at the HL7 organization. And it's a collection of lots of different organizations who are involved in creating these workflows that are specifically focused. In the Vinci case, they're specifically focused on payer, provider, and patient data exchange. And so payers and providers and EHR vendors, vendors like us, implementation vendors, industry partners, all get together to put our minds in the same room about what are challenges between payers and providers and patients that FHIR can solve. What are those workflows? And then let's address those workflows and put a consistent way in place that everybody will exchange data the same way. So that's kind of the focus of the group. And then out of that comes implementation guides that are published that say, here's exactly how you do it. Now, if you go to the next slide, the implementation guides that are published are listed here. And so these are use cases, or a more technical term would be implementation guides that are published by the Vinci organization. Now, the Vinci organization has been around for many years. Some of these use cases are more mature than others, and some of them are actually already aligned with or tied to CMS mandates. And so a green workflow would be one of the ones that's been around for a while, that's been most mature. Blue would signify active growth, and the orange would signify something that's relatively new and least mature. There's also flags next to some of these workflows as well. You'll see a red asterisk that represents that this particular workflow is already incorporated in a final rule that's been issued. And so the final rule may say payers must exchange data with other payers, but the specific implementation guide says how that will be done, or how that should be done if everybody wants to do it consistently. The red diamond, which is represented by some of these workflows, says that it's aligned with a federal regulation, meaning that maybe it's included in a proposed rule right now, or it's not final, or there's some other type of knowledge that leads us to believe that it will be in a federal regulation at some point. So all three of the workflows that we'll look at today are either referenced in a federal regulation or aligned with an expected federal regulation. And so the three we'll be looking at again are, one is going to be clinical data exchange. So in the upper left-hand corner, you'll see the clinical data exchange workflow. It's an active growth workflow, been around for a while, but not quite to that most mature stage yet. And it is aligned with an expected federal regulation. So when we're at Infor putting our products roadmap together and our strategy, we want to make sure we're aligned with what's going on in the industry, and that our customers can do these workflows that are expected, especially if they're going to be in federal regulations. And so that's why clinical data exchange is certainly a focus of ours. Next to that is payer data exchange in green. So this is a very mature workflow. And one of the reasons it is mature is because it's already in a federal regulation. And we'll talk about which regulation that is. And then finally, in the upper right-hand corner is prior authorization. So prior authorization is again, active growth. It's expected to be in a federal regulation, and something that we're working on and have tested out actually at CMS Connect-a-thons. So if you're not familiar with Connect-a-thons are places where vendors can go together along with payers and providers to test out these workflows to make sure they work before we actually go try to implement them in the field. Some of them are hosted by HL7, some of them are hosted by the CMS. And the CMS, of course, will focus on those that are either in their rules or are going to be in their rules. Earlier this year, in the summer timeframe, we actually went to the CMS Connect-a-thon virtually and tested out these three workflows to make sure that we could achieve trading data with other vendors for these particular three workflows that we'll go through today. And then since then, there's been an HL7 Connect-a-thon where we also tested some of these workflows as well. All right, so let's go to the next slide and look at our first workflow. So our first workflow is going to be the payer-to-payer data exchange. So this enables one payer to share data with another payer based on movement of a patient from one payer to another. So suppose you change jobs, you get a new health insurance plan, and you want data from your old payer to be sent to your new payer. You can request that today, and the old payer should send the data that it has to the new payer to be incorporated in your records at the new payer. This is part of the CMS final rule, which is CMS 9115-F. The deadline to have this implemented was January 1st of this year. However, the CMS did make a notification that the enforcement would be deferred. So the deadline remains, but they're not enforcing it yet. And they haven't specified an enforcement date yet, but we're expecting that sometime soon to have that enforcement date defined. And then at that time, that'll be the real deadline where you certainly have to have this payer-to-payer data exchange done for exchanging data as a patient goes from one plan to another. So how does this happen? How does the patient request the data? And then how is how would it work that payers would exchange data and all do it in a consistent way. That's what we'll look at in the next slide. So next slide, please. This is actually a summary of what's in the implementation guide, what's published by the Vinci organization for this particular workflow. And the link is in the bottom left-hand corner to go directly to it and get more details. But I'll walk through the summary here, and then we'll show how it's actually done in the product. And so when a patient or member goes to their new payer and they request data from their old payer, the first thing that the application has to do with the new payer is it has to authorize itself with the old payer. So the new payer would tell the old payer, I want to get data for a member using what's called a member match operation. And then the old payer, if there's registration has taken place already, we'll send back a token, an authorization token to the new payer to allow them to go access their systems and get this data. So authorization happens first. Once that authorization is achieved, then there's something called a member match operation in the FHIR world. And so what member match does is it allows a match to take place between the new payer and the old payer. And in order to do this, you're going to need a variety of data. You're going to need patient demographic data. You're going to need coverage data about the old payer, and you're going to need a consent as well to show that the new payer or the member at the new payer has indeed consented and wants this data sent to the new payer. The application at the new payer needs to go gather these three things: the demographic data, the old payer coverage data, and the consent data, package that up and send it over to the old payer so they have all this information. And that's all done in this FHIR member match operation. Once the old payer gets this data, then they can look at it and determine, yes, there's consent. We recognize the demographics. We recognize the ID from the coverage. So we have all this information. They will respond back with, here is the member identifier we want you to use to get information about this patient. So they will pass that back along if everything matches up. And then the new payer can get can authorize itself again to get information about that specific member. And then it can do what's called a $everything operation to get everything about that patient sent back to it. In the FHIR-based world, this is another operation, $everything. If you haven't heard of $everything before, it's just a simple way in FHIR to say, I want everything about that patient. I don't want just the patient demographics. I want all the clinical data that's tied to that patient sent back to me, so I have a full patient record. So that's what's referred to as the $everything operation. And that's the final step of getting data from the old payer. Once a new payer gets that data, then it can merge it into its existing records with the information it already has on the new member. So those are the steps that need to go through in order to make all this work. And with that, I'm going to turn it over to Viken, and he can show how it works in the product. Viken, you're on mute.
Okay, there you go. Yeah, thank you. So I would like to start this demo by kind of showing and talking about what actually happens behind the scenes inside Cloverleaf. So Rob went over all the various steps and the workflow that needs to happen, right? So let's kind of take a look at that first, right? For those of you who have already worked with Cloverleaf, you're probably already familiar with this screen. So this is the what we call the network configurator. And each one of these boxes that you see on here represent a connection, right? So the first one here, this orange box here, this is actually a web service provider, right? So this is the entry point into Cloverleaf. And then these two blue boxes here, these are the consumer connections to the FHIR servers. So with this particular workflow, we're actually dealing with two FHIR servers. We're dealing with let's call it the new FHIR server of the new provider, and then the old one of the old provider, right? So we're gonna actually be querying data and posting data to both of those FHIR servers. And then in the middle here, so this is where the bulk of all this workflow orchestration happens, right? So here we're using a protocol in Cloverleaf called the DTC, which stands for Distributed Transaction Controller. And I'm going to open up the properties of this DTC connection. So this is a protocol in Cloverleaf that is used to build orchestration workflow, right? So we can define steps and then transitions between each one of these steps. So the steps that are defined here, I'm highlighting them here. So the first thing that's going to happen here, once we get the request from the patient portal, we're going to request a token, right? Authorization token, so that we can go and to our FHIR server and get the patient, the resources for the patient, the consent, and the coverage, right? So these are all the steps that Rob was talking about. So once we get all this information into Cloverleaf here, Cloverleaf is going to construct a member match bundle, and we are going to send or post this member match bundle to the old FHIR server. And this is where that FHIR server is going to respond, and it's going to say, okay, yes, I recognize all this information, and here's it's going to return to us a unique member ID, right, for that particular patient. Then that member ID, we're going to use it to request a token from the old payer's FHIR server. And once we get that token, then we can go and request this $everything PDex action from the FHIR server that is going to return all the coverage information for that particular patient from the old FHIR server, right? So now we have all this information, then we can turn around and update our new FHIR server with all this information, and that's it. So there's quite a bit of, of steps and transitions that happens that are defined inside this DTC protocol properties. So with that said, so that's kind of laying the groundwork. I'm going to use Postman to simulate the patient portal. So from Postman, so this is our request here, right? So this is the IP and port of my Cloverleaf web service provider. We're going to pass it the patient ID and the coverage ID, right? So what's going to happen here, once I click send, Cloverleaf is going to go through all that workflow that I was just describing, and there you go. And for the purpose of this demo, I'm returning the response of the bundle post from my FHIR server. So what we're seeing here in the response is that the contents of that $everything PDex action that we were talking about. This of course contains multiple resources, right? And each one of these sections here represents is the response of the posting of each of these FHIR resources into the new FHIR server. So after all this is said and done, then the new FHIR server is completely up to date with all the patient's information from the old payer's FHIR server. So that's it. So that's pretty much the payer-to-payer workflow. So with that, I'm going to pass it back over to Rob.
All right, thank you, Viken. And so now we'll talk about our second workflow, which is clinical data exchange. And similar to pair-to-pair data exchange, this is going to involve a series of steps. And so when you transition data from one organization to another, there's typically a series of steps involved. You just can't go and request the data and get it back and do it in one simple task. It typically requires, a workflow orchestration, a collection of a series of data that, the other side may need just to verify, who you are and what information you need. And so that's pretty common in these implementation guides for FHIR, and that's why they exist. If FHIR was simple, just request data and get it back, you wouldn't need implementation guides, and you wouldn't need groups like the Vinci group and all the other accelerated groups at HL7. So just a good example of kind of the complexities that are involved and the type of software tools you need to make this happen. So with clinical data exchange, this is focused on getting data from providers. So with payer-to-payer data exchange, obviously we were getting data from a payer. For clinical data exchange, we're getting data from a provider. So payers or providers can request data from another provider. And some of the example scenarios are listed here. It could involve exchanging clinical data between referring providers. It could involve requesting attachments to support a claim that was submitted. It could involve quality programs or risk adjustment, or it could be tied to prior authorization, where a prior authorization was submitted, but the payer needs more information, so they request that additional information from the provider. So let's go to the next slide, and we can look at the series of steps involved for clinical data exchange to achieve that. So on the data consumer side, this would be who's requesting the data. They, of course, have to authenticate, but once they authenticate, then they can request the data needed. And in this case, there's a couple of different flavors of clinical data exchange. What we're going to be talking about in this particular example is the task-based data exchange. So we're going to request the data in a task resource. So we're going to be giving the data source or the provider a task to go get data for us. So in that task that we send over, we request what data we need, and then the data source responds back and tells us, gives us a link that we can use to poll or to continually check to see when that data is ready, because it might not be ready immediately. So we can use that URL or that link we get to poll for status. In the meantime, the data source on the other side needs to go gather the data, but then they also need to verify that that data really can be sent or should be sent. And this can be manual intervention, or it could be, an automated check that's done. But in any case, the task-based workflow for clinical data exchange is meant to have that verification of validity to make sure that the data indeed should be sent. And so then once the data is gathered, the data source will change that task to completed, so that when the data consumer is polling, it'll see that the task resource now says completed. And once completed, that task resource will have another URL that the data consumer can use to go actually get the data. So then they use that, the data consumer uses that final URL to request the data from the data source. And then that data is returned as a bundle with FHIR resources that the data consumer can then use for whatever purpose they're using this for. So those are the series of steps. Once again, you need to be able to do workflow orchestration to achieve this on both sides. And so I'll turn it over to Beacon to show how that's done in product.
All right, thanks, Rob. Okay, so yeah, let's do the same thing for this demo. Let's talk about what happens behind the scenes. So in this case, we're dealing with only one FHIR server, right? So it's not going to be as intensive as the previous demo. So so again, we have a connection, a web service provider connection, a web service consumer connection that goes to our FHIR server. And then in the middle, we have the same DTC protocol that we used earlier. However, in this case, I'm going to display the steps in the DTC this time. As you can see, that it's not as intensive as the previous demo, right? So in this case, the request that is going to come in is going to be a task resource, a FHIR task resource. So inside the task resource, and I'll show what that looks like in a minute here when I do the demo with Postman. So inside this task resource, there's going to be a FHIR request, right? So the first thing we do here once we get that request is we actually execute the request, or the query, I should say. We execute the query against the FHIR server. So that query can be, a resource, multiple resources. It could be pretty much anything, right? Once we execute that query, the FHIR server is going to respond back with the bundle, right, of all the information that we requested. we then take that bundle and we store it back to the FHIR server and obtain a unique bundle ID for that information. So at that point, this is where the manual intervention has to happen. It can be either manual or automated depending on the system. So that request has to be marked as completed, right? So at that point, the data consumer, whether it's a patient portal, a payer, or whoever, can then query our FHIR server to see, hey, is my data ready to be consumed? And once it's completed, then that data consumer can go and retrieve that bundle. So let's switch over to my Postman. Make sure everything is up there. Okay, so I'm going to switch over to my Postman here. And so we're going to use Postman again to simulate the data consumer, right? So what we're going to send is this task, right? So this is a task resource. And I'm going to just point out what's, what really matters to us in this task resource. So here's the query that has to be executed, right? So in this particular query, we have the patient ID, and then we have all the parameters for that patient that we're looking for. So once I hit the send here, so what's going to happen here, again, it's going to go through all that workflow I just described, and the response that comes back, right, it's going to be a task response. And the status of this task response is in progress. Now, what's going to be interesting here, if I look in the headers contain this content location, right? So the content location is going to contain a link that I can use to poll the FHIR server to see if this request has been completed. So let's go ahead and do that. So I go here and paste that link here, and we're going to do a get operation. This is going to return another response. And again, right, for the purpose of the demo, the response that is being returned here is going to have a status of completed, right? So there's my completed status. So now I know that my bundle is ready to be retrieved. And in addition to this completed status, this has this value reference, right? So I can use this link here to go and retrieve my bundle. So again, I'm going to do another get operation. I'm going to send it, and what I get back this time from the FHIR server is my the bundle that contains all that information that I had originally sent in my task resource. So that's it. That's the entire workflow of the CDex operation. So back to you, Rob.
Thank you, Viken. And now we can move into our third workflow that we'll be discussing today, and this is prior authorization support. So prior authorization is something that's is part of burden reduction, but is seen as in the industry as something that has a lot of burden to it. There's a lot of back office activity that needs to take place to send faxes, to cut and paste from maybe an EHR to a payer portal. And then it involves a lot of wait time for the patient as well. So they're waiting to see if they'll get approved for a procedure. They don't know. There's a lot of stress. And so it's something, both for, reducing the burden of the back room and also for the courtesy of the patient, so they're not waiting so long to get a prior authorization, that there's been a real focus on this in the industry. And so part of that is this prior authorization support that allows it to be done in a FHIR-based way. So what this implementation guide does is it defines FHIR-based services to enable the provider at the point of service to request prior authorization, and that prior authorization will include all necessary clinical information to support the request. So all of this is included in one big FHIR bundle to make that request, and then include all the other information that might be necessary to make that decision. There should be a response that comes back immediately from the payer on the prior authorization. It could be a pending, that we don't know the answer yet. But hopefully, if all the information is included, there's an automated decision that can be made that would give an immediate response back, so the patient would know right away as to whether that prior authorization is approved or not. And then one final note on prior authorization, it incorporates HIPAA requirements. And so the HIPAA requirements for prior authorization say that prior authorization must always be done in the X12 standard, the 5010 X12 standard. And so that hasn't changed. And so what that means is, at some point along this exchange of data, the data needs to be converted to X12 just to meet HIPAA requirements. But in most cases, it also needs to be converted to X12 just so it can be sent to the legacy systems that the payers might still have. But it allows the provider on their side to see everything in a completely FHIR-based way. And so on the next slide, I took this particular chart from the implementation guide posted by the Vinci group. And it shows kind of all the different places where this transition from FHIR to X12 can take place. It may take place at a clearinghouse. It may take place closer to the provider or over on the payer side. But the main thing is that from the provider's perspective, when it comes out of their EHR, it'll be FHIR based. And then at some point before it gets into the payer systems, it'll be converted to X12 somewhere along the way. Now, there are some exceptions that have been granted to this where it can be FHIR based the whole time, but the general rule is that still, based on the HIPAA law that's in place, that it needs to be converted to X12 at some point along the way. And then, like I said, in most cases, the payers are going to have their legacy systems which know X12, so they'll want it in an X12 format anyways on the payer side. So we have the ability to do this in our product to make this translation from FHIR to X12, and I'll turn it over to Viken so he can show you how that works.
Okay, thank you, Rob. Okay, so this particular demo, this is more. So here's the network configuration for this demo. So this is more the traditional Cloverleaf interface, right? We're getting data in one format from a source system. We translate it to another format. We get the response and translate it back. So in this case, there's no workflow orchestration like the previous two demos, right? So in this demo, we're going to use, again, right, we're going to use a web service provider thread that's going to simulate a FHIR server. This connection here, this web service provider is going to receive a claim request in FHIR format. We're going to take this claim request in FHIR format. We're going to route that to this connection here. And by the time it gets to this connection, that data will be converted to X12. And just to show you real quick, this is the transformation. This is the Cloverleaf translation file that we will be using. So the input message format is a JSON FHIR R4 bundle schema, right? And the output is an X12 version 5010, as Rob mentioned. And this is going to be a 278 transaction in X12. So this 278 transaction then will get routed to this this connection here that simulates a payer legacy system, right? That only consumes X12. This will convert. This will return another 278 as a response that will then get converted back to a FHIR claim response bundle. So that's the workflow. So let's go over to my Postman again, right? So in this case, we're using the claim $submit FHIR operation. So this claim $submit is going to expect a FHIR claim bundle, right, which is right here. So once I hit the send button here, it's going to go through all the translates that I just mentioned, and the response that we receive here is again, right, again a FHIR bundle, but this time it's a claim response, right? So this claim response is actually the response from our legacy system simulator that came in as an X12. So if I switch back over here, and let's go ahead and look at our SMAT here. SMAT is the Cloverleaf archiving utility. And in here, we can see that if I look at my content, so here's the FHIR bundle that was received, right, in Cloverleaf. Then let's open up the archive of this connection here. So again, right, remember by the time we hit this connection, it's going to be in X12 format. There it is. So there's my X12 transaction, right? So again, right, the information is the same. It's a bundle, right? However, the format is no longer FHIR, it is now X12. And then vice versa with the response that comes back, we take an X12 and convert it back to a FHIR claim response and send it back to the data consumer as a reply message. So that's the workflow of this particular demo. So Rob, back to you.
Thank you, Viken. And so that wraps it up for the 3 workflows that we wanted to demonstrate today. We did pair-to-pair data exchange and clinical data exchange, which required a lot of workflow orchestration, and then finally wrapped it up with prior authorization, which requires some mappings that are going to be necessary to integrate FHIR into payer legacy systems. And with that, I'll turn it back over to the moderator.
Okay, great. Thank you, gentlemen. So we've already had some questions coming from the audience. However, we would also like to remind you to use the Q&A box to the left of your video window at any time.
Okay, let's see here. The first question I have for you, gentlemen, is why does the second demo not need FHIR server on both?
Okay, yeah, that's, I guess, a good question. And I'll kind of answer it as it could have a FHIR server on both sides, but it doesn't necessarily have to have a FHIR server on both sides. So, for example, if I'm a provider requesting data from another provider, I request that data using the task resource like Beacon showed, and then I eventually go get my bundle and get my FHIR resources back. I may have a FHIR server that I then want to take those FHIR resources and just load it into, but it could also be the possibility that maybe I have some legacy systems that need that data. And so I may need to, parse apart those FHIR resources and load them directly into my legacy database. Maybe I need to load them into an application that only accepts HL7 v2. So I need to convert FHIR to v2 to make that happen. And so, as the industry, transitions forward from legacy type, exchanges to FHIR type exchanges, there may not be a FHIR server on both sides. And so I think, during the demo, that's what we were trying to represent, was that, you don't always have to have a FHIR server on both sides as the industry is kind of transitioning and there's still a lot of legacy systems in place.
Okay. The next question I have is, why are all these workflows moved to FHIR?
Yeah, so, I think the CMS and the ONC have, definitely, played their hand that they want integrations moving forward to be based on the FHIR standard. And so, why is that, I guess, is the question in general. And I would look to, modern-based technologies that FHIR affords itself to. So you're looking at using a encoding format in JSON that is readily accepted and known across all industries of a way to encode data and exchange data. And there's lots of tools to support that. Utilizing web services, all apps utilize web services. And so these are things that app developers know and that developers in general know, using web services, using JSON, and using resources that that the JSON objects represent, and packaging data in a nice way for healthcare and making it simple in that sense of creating FHIR resources that are all packaged in this that they each have their own definition of what they represent. It's just structured in a nice way, and it uses modern technologies. And so I would say those are some of the key reasons that that the CMS and ONC have pushed these mandates to utilize FHIR, is just the modern technology and the ease of use in using FHIR compared to the more kind of structured legacy ways that we've seen in the past that are not really app friendly.
Okay, great segue. Next question. What is the best way to keep track of government mandates in these specific workflows?
Oh, okay. Wow. So with regards to keeping track of government mandates, myself, there's, I guess one kind of weekly update I follow is just from healthit.gov. So if you go to healthit.gov, you can sign up for a weekly update and get updates on, what's going on with rules and regulations. That's a good way. But then, there's a lot of accelerator groups at HL7 that are working on workflows that are kind of innovating with FHIR. That it's good to follow those work groups as well. So obviously today we're talking about Vinci. Vinci is one that focuses on payers and providers and patient data exchange. So you can go to the hl7.org website and go to their accelerators and look at Vinci. But then there's lots of others as well. There's Vulcan, which focuses on clinical research. There's Gravity, which focuses on social determinants of health, and others as well. And so you can go to those work groups to kind of get a feel for, depending on what your interest is, go to the particular work group and then look at the workflows that are being done in FHIR to kind of get a feel for, what's progressing out there, what people are trying to innovate with regards to these certain, accelerator groups and their focus. And it's just a good way to keep track of how FHIR is developing, I think.
Okay, on to the next question. Can I use my EHR to address these workflows and other FHIR workflows?
Yes. So, with the end of this year, all EHRs are going to have a FHIR API available based on the 2015 Cures Update certification standard. So certainly all EHRs are going to have a FHIR API. When I kind of like to, I guess, draw the analogy of when HL7 V2 was becoming popular in the 90s and early 2000s. There was a lot of point-to-point communications between HL7 V2, between EHRs and other applications. And then, as time progressed, one connection became 2, became 5, became 10. And at some point, especially as it becomes hundreds, you can't really keep up with all those point-to-point connections. And so then stepped in integration engines like Cloverleaf and others that are on the market to kind of fill that need as a middleware product. And I feel the same thing will happen with FHIR to where, if you have just a few workflows you're trying to address, you can certainly address those with that FHIR API that comes with your EHR. But as time moves on, you're going to have two challenges with FHIR. One is you're going to have lots of APIs, lots of different apps that want access to that FHIR data. And so you're going to run into the situation of trying to manage those all. And your EHR is not focused on API management, they're focused on being an EHR. So you need that middleware tool to kind of manage all those APIs. But then as you saw today, these are not simple, just straight data exchanges like we have with HL7V2. These are more workflow orchestration type data exchanges where you need to go get data, request things, get back things, request more things. And so you're going to not just need, API management built in, but you're going to need workflow management built in, specifically with knowledge of FHIR, orchestration. And so the answer to the question at a high level is yes, your EHRs can have a FHIR API and can exchange data in FHIR, but to really solve or to implement these implementation guides and all the orchestration that requires, there's probably going to need more tools, moving forward that can be that more intelligent middleware type product, just as we had for V2. We'll need that for FHIR as well.
Okay, the next question is, how do these workflows improve patient care?
Yeah, so I think they all tie back to patient care at some point. For payer data exchange, I think the emphasis there was that, as a member moving from one payer to another, that having that data could help with wellness programs. It could help with quicker prior authorization by having that, historical data view. For clinical data exchange, kind of similarly, having more data available from other providers at the point of care certainly can help, with patient experience and quality of care. And then, with the X12 FHIR conversions, if we get to a point where prior authorizations are quicker because we're doing them in a FHIR-based way, certainly that alleviates some stress on the patients. And so, I think all the workflows that are being addressed, whether it be by Vinci or other accelerator groups at HL7, the focus is always at the end of the day on how to improve that patient experience and the quality of care for the patient. It may not always be readily apparent at the front, but if you drill down, I think there's always that motivation of patient experience and quality of care.
Right. So the next question I have is, you showed the transform claims and claim responses from FHIR to X12. Does the workflow also generate 278 transactions?
Yeah, so the 278 transactions are for prior authorization. So that's what Beacon showed. Those are 278. There's an inquiry and a claim. There's also a 275 additional information that is kind of related to that. We don't have the 275 additional information mappings done yet, but that's the next step to work on those. And then, of course, there's all other kinds of X12 transactions that are out there as well. But right now, our particular focus has been on what's coming up or what is in a proposed rule and will likely become a final rule is the 278 transactions for prior authorization.
Okay, the next question I have is, what is the difference between HL7 V2 and HL7 FHIR standard?
Yeah, so HL7 V2 is kind of the legacy standard, the old standard, and HL7 FHIR is the new standard. And so, the HL7 V2 standard has been around since the 90s. And it is a structured data format. And so it's delimited by nature. So you have pipes and hats that kind of delimit the data. And if if you count a certain number of pipes or a certain number of hats, exactly what data is supposed to be where. And if the application on either side, has that intelligence to know how the data is delimited, then they can parse apart that data and make use of it. So it's worked really well in the industry for decades, right? And big systems or big applications that have the ability to do that type of parsing, it works great for them. Where it falls short really is this ability for kind of nimble and efficient development, because apps don't parse apart data like that, right? And there's also this this notion or this problem with talent pools of IT developers know XML, they know JSON, they don't know this very proprietary format of HL7 V2. And so with FHIR is based on JSON, and there's also an XML version as well. And this is a more well-known technology that can be used by IT developers. And then it's also sent via HTTP web services, of course, which is used by app developers across industries. And so with FHIR, you have the same clinical data that's transferred, but it's transferred in a modern format, primarily web services and JSON, that are well-known technologies and easier to implement and especially for mobile apps that they can utilize the data that's encoded in JSON, versus those have been stumbling blocks for healthcare because of the legacy HL7 v2. It's difficult to do those things and difficult to incorporate into mobile apps.
Okay, so this question has a few different points to it. Is there an existing FHIR work group that meets weekly that I can join to learn more? Does your company facilitate those kinds of meetings? Or maybe is this done with HL7 org membership?
Yeah, so those are all kind of related, right? And so there are weekly meetings to develop these standards, absolutely. And so you can go to the HL7 website, and there's a calendar button on the HL7 website. So the HL7 website is hl7.org. You go to that website, and there's a calendar there. You can click on the calendar, and there's going to be like lots of meetings every day that you could potentially join. And so you got to kind of figure out, okay, well, which one is one that's really interesting to me? And that's where you can go to those accelerator groups. So you can first click on, Da Vinci or any of the other accelerator groups. If you're interested in social determinants of health, you could go to Gravity Accelerator Group and see what workflows they are working on specifically. And then each one of those workflows has a weekly meeting, typically. Some of them are monthly, but most of them are weekly, that is tied to it. And so then when you go to the calendar, you can say, oh, I want to go to the prior authorization support Da Vinci meeting every week. And so you can go and see that meeting's on Thursday afternoons. You can sign up for it. You can get it on your calendar. And anybody can go to those meetings, those working meetings, and help out, get involved, just observe, see what's going on. So there's nothing that is required as far as the HL7 organizational membership. They'd be happy for these weekly meetings. They'd be happy for anybody to attend and get involved. So you don't have to be an HL7 member to do that. You can just, like I said, you can go to the calendar on the HL7 website and sign up or find out when it is, put it on your calendar, and there's not really any signing up. It's just putting it on your calendar. And go to those weekly meetings and see what's going on and participate. As far as Infor goes, do we facilitate? We don't facilitate the meetings. We are members of the HL7 organization and some of those work groups, and we go to the meetings and participate ourselves, but we don't facilitate any of those meetings.
Okay. Well, unfortunately, that is all the time we have for today. I would like to thank our presenters for today's excellent webinar. I would also like to thank Infor for making today's program possible. Finally, I want to thank everyone in our audience for joining us. We hope you'll join us in the future for another healthcare innovation webinar. This concludes today's presentation.